Welcome to Pediatric Grand Rounds. I know people will be filtering in, but we're going to go ahead and get started. I'm Jerry Vockley. I'm the Chief of Genetic and Genomic Medicine here at Children's and Director of a program called the Center for Rare Disease Therapy. I bring that up because today is our celebration of Rare Disease Day. Rare diseases are not are individually rare, but together added up, they're about excuse me, at least a few percent of the population, and so it's a bigger issue than most people realize. The National Organization of Rare Diseases, NORD, a number of years ago started recognizing February 28th and especially February 29th as Rare Disease Day, and has really tried to bring awareness to those conditions through that effort. I mention this today because not just that it's our rare disease celebration, but this is indeed the first part of that. We are going to start. We have a rare disease program going on throughout the day, starting with Dr. Ghaloul Gonzalez's Pediatric Grand Rounds this morning, but then continuing later in the morning at 11 o'clock. There's another session here where there will be four 15-minute presentations on some activities surrounding the Rare Disease Day and our rare disease program, followed by, wait for it, a taco bar that will include a poster session too, just in case you're interested in that. So those will show some of the work that goes on in our division and other divisions around the institution along for rare diseases. So today, it's my extraordinary pleasure to be able to introduce today's Grand Rounds speakers, and I'm going to read this so I don't forget anything. That would be horrible to forget anything. Dr. Lina Ghaloul Gonzalez is Assistant Professor of Pediatrics and a physician scientist here in the Division of Genetic and Genomic Medicine. She received her medical degree from the University of Aleppo School of Medicine in Aleppo, Syria, and then completed her residency in internal medicine. Yes, internal medicine. Genetics is not a pediatric subspecialty. I can talk to you about that afterwards if you want. At State University of New York at Buffalo. Following that, she came here and did her residency in medical genetics and genomics, and then a fellowship in medical biochemical genetics. She's board certified in all three specialties. In 2016, Dr. Gonzalez co-founded the program that she's going to talk about today, the Plain Community Translational Medicine Program here at UPMC and Children's, with a goal of advancing specialized genetic care and research for Amish and Mennonite patients in Western Pennsylvania. Her lab conducts functional studies of novel gene variants and genetic disorders identified within the Plain community, and has identified several novel genetic conditions within this community already. Dr. Gonzalez also focuses on investigating pathophysiology of TANGO2 deficiency disorder seen within the Plain community initially, and now being identified more frequently in the general population. If you've never heard Lina speak, you'll recognize immediately her passion for outreach and serving serving underserved communities, and this is shaped by her lived experience within diverse cultural, religious, and socioeconomic environments. This is reflected in her work with the Plain communities, and more recently with physicians and families in Ecuador, helping them deal with their burden of inborn errors of metabolism. So with that, I've taken enough of her time. I'm going to turn it over to Lina. Please welcome Dr. Gonzalez.
Hey, good morning, everyone, and thank you, Jerry, for the nice introduction. Some of you have heard different versions of this talk, but hopefully it will still be interesting for all of you. So I'm going to talk about the Plain Community Translational Medicine. I'm going to talk about the Plain Community Translational Medicine program that we co-founded here at UPMC. I have no conflict of interest. So the plain communities originated from Central Europe, from Switzerland, Switzerland and part of Germany. That was in the 1500s. There's currently about 2.1 million worldwide, and that was with the Anabaptist movement. Some of these, there are three main groups of this Anabaptist in the US. There is the Old Order Amish, which is about 410,000 in the US. There are Mennonites, about 70,000, and Hutterite group, about 50,000. However, the Hutterites are usually in the upper Midwest and Canada, so they're not in the Pennsylvania area. There were several migrations from Europe to the United States because of the religious persecution, and the first major migration to the PA was in the mid-18th century. And currently, we have about 95,000 Amish individuals in Pennsylvania and 51,000 of Mennonites. This is a heat map that is showing the Amish population. This is per the Elizabethtown College. They have the Young Center, which really have enormous amount of data about Amish and Mennonites in the US. And maybe a lot of people think about plain communities as being in Ohio and Pennsylvania, but as you can see from the heat map here, they are actually spread in several states in the US, but you can see that the highest distribution is in Pennsylvania with the highest, about 95,000, and in Ohio and Indiana, but there's also in Wisconsin, New York State, and different states in Indiana. From the Elizabethtown College, the Young Center, these are the statistics which show the differences between 2015 and 2025. So the population is growing really fast, and I show in the next slide how the growth is. But when we talk about Amish, we talk about settlements, which is larger grouping. And then within these settlements, there are districts. So the districts are usually church districts, and within each district, there is about 20 to 40 families. And anytime that these districts or settlements grow, then there was a new settlement. So you can see here in a 10-year period, there was increase in the settlement number from 54 to 63 in Pennsylvania alone. So that's an increase of 9. And then there was increase of the district of 171 in 10 years. And the population keeps growing. Per the Young Center, the Amish population doubles about every 20 years. And that's what makes it very important to know about the genetic condition in this population and provide the best healthcare for these communities. As you know, the plain communities, Amish and Mennonites use horse and buggy for transportation. Usually they are large families, so we find between 8 and 10 kids sometimes. We have some smaller families, but this is a typical family that we see. And with this one, this is probably one of the church days, like attending church. So you see the horse and buggies there. The churches for the Amish is usually in their homes. Mennonites, they have their own churches. And I will talk later, like where we met different families for different studies from the Amish and Mennonite. But the buggies have different colors. You see here the black top buggies. There are white top, yellow top buggies, and there is also gray. And each color is for a different group of the Amish or Mennonites. What is also interesting and good to keep in mind is that Amish people don't learn English till they go to school at age 5. So they have Amish schools within their communities. It's usually one classroom, and it's taught by a teacher that is from the Plain community itself. There are all kids from different ages, different grades, from the first grade till 8th grade. They are in the same class, and the older kids teach the younger kids with the teacher involvement as well. This is important to keep in mind because anytime that we have patients that they are younger than 5 years old, they won't understand English, and we communicate with these kids through their parents that they translate to Pennsylvania Dutch, which is the language that they speak between them. So probably many of you have heard them here in the hospital talking a different language. So that is a specific type of German language, so called Pennsylvania Dutch. But just keep in mind that younger kids don't understand English. So if they don't answer you, is because of that. Our program started because of a study that we did. This is one version of the study, but I'm going to talk a few years ago, and in 2015, actually, so more than 10 years ago, we had a patient with Mila's syndrome. So she was 13 years old. She came with stroke-like episodes. She was seen at Children's Hospital by Dr. Walkley and Dr. Amy Goldstein then. And at that time, we realized, there were family members affected that we didn't know about. And I'm going to talk about this later. But at that time, we realized that there are many of the genetic conditions and patients that they are seen here at Children's Hospital that we don't know what kind of genetic conditions they have. And because of that, we did 2 studies. One of them was before this one that is here, looking actually at common last names for patients from the Amish and Mennonite community, like Troyer, Miller, Byler. The Miller was a little bit challenging just because Miller is also in non-Plain community. And we looked at the charts of these patients to see how many would have benefited from genetic evaluation and how many of those we were called to consult. So we did really see a lot of people that we were not called for consult, and this is why then we did formal QI study with Sarah Ehrenberg here, who was a medical student. And at that time, we took a 1-year period where we looked at all Amish and Mennonites presented here. So that was by looking at the race and ethnicity. So if the race and ethnicity missed that, so we're missing these patients. But in that 1-year period, there was 303 Amish and Mennonites patients. Looking and reviewing all the charts, about 102 or 1/3 of them, they would benefit from at least comprehensive physical exam and genetic evaluation. We were called only for 32, which is 1/3 of those that they would have benefited from having genetic evaluation. And at that time, we realized that we really need to spread the word between the word for other physicians to know about this. So you can see here also in this map, the numbers. These are where the patients came in from different areas of Pennsylvania that they were part of this 303. And on this side here, the blue stars are for the Plain communities within Pennsylvania. The red stars are for the clinics that they are available. This one in Lancaster is the very first Plain community. It's called the Clinic for Special Children, which was co-founded by Dr. Holmes Morton about 35 years ago. Dr. Morton moved about 10 years ago to Belleville in central Pennsylvania. So you can see that this area, and we know a lot of the genetics of Plain people in eastern Pennsylvania, why we didn't really know much about the western Pennsylvania. So this is UPMC Children's Hospital, and this is where we have the outreach clinic in Mercer County. And it is within an area where there's a lot of Plain people. Just something to note that Plain communities have genetic conditions that they are prevalent in different communities, but then each community have their own genetic conditions. This was originally the people that they started with this. So Jerry Walkley, Kate Walsh-Walkley. So Kate just retired in the summer of 2025. She was the senior genetic counselor, coordinator, and manager. So she did a lot with this program and community. My involvement at the beginning was more on the research side, and Dr. Walkley used actually to go to Mercer County to the outreach clinic, from a couple of years later, I was the main one going there. We have Ali Smith, who's the metabolic dietitians, and because we have some patients with metabolic disorder that we need to manage their diet with a specific diet and formulas. So she comes with us first Tuesday of every month to Hermitage, and we have Jerome, who's substituted Kate, the new genetic counselor since this summer. If you remember the heat map that I showed you, the plain communities are in different states, but they are mostly here in the eastern north, states. And you can see with the red stars is where the different clinics are. We are all part of a growing consortium. It's the Plain Community Consortium. So there are clinics, so the clinic in Lancaster, for example, the clinic for special children, they provide primary care, but they also provide genetic evaluation. We, in our outreach clinic, only provide genetic services. So this is why we are affiliate, and there are main clinics. So these are the different clinics that they are there. There is also University of Exeter in the UK, and we collaborate with them. They have the Windows of Hope project, and they've been working with the different plain communities here in the US for the last 15 or 20 years. Through our outreach program, we do provide clinical services, and also we have the research program as well. The clinical services is like for any other patient that we see in the genetics clinic. So we have the outpatient clinic at Hermitage. We have also we see the patients here when they are admitted and in the clinic. And we do the medical and biochemical genetic evaluation, genetic counseling, which is very important because sometimes we have one affected individual and suddenly we have several in the family, or we do carrier screening for the specific genetic condition. Nutrition also is another part for the metabolic conditions. And we used to, especially at the beginning, have neurology come with us to these outreach clinics. So Dr. Amy Goldstein at the beginning, then Dr. Deepa Rajan. We currently don't have a neurologist that comes with us to these clinics, but if we have patients that they need any of the subspecialty services, then we can refer them. Some of these services like GI cardiology, they are in Hermitage, close to where they live, but also we can refer them to Children's Hospital. Especially when we started, we wanted to do some community engagement and let the plain communities in Western Pennsylvania know that we have the outreach clinic. And we did that in culturally appropriate manner. So we did go to Amish gathering, and you can see here, this is actually one of the events that we went to. It was an Amish Safety Day in a firehouse there, where they teach how to use the car seat or provide immunizations. So we were there. There was neonatologist, genetic counselor. Kate was there as well. And we did also provide mailing for individuals and doctors in the UPMC system. But we also did put ads in community publications. There's the Just Plain Values, which is not specific for the plain community, but the Die Botschaft and the budget, they are specific for the plain people. So we put ads in their papers so they get to know about our outreach program. We did also do word of mouth. So that's talking with the public health nurses to let them know about our program. And midwife education, and Kate was involved with this one very heavily with the cardiology, mainly to do education for the midwives for pulse oximetry as part of the newborn screening, because it was not done by the midwives to screen for congenital heart disease. The reason why we go to the outreach clinic is because we want to improve local access. As I just told you, so they don't drive and they have to pay for drivers about more than $1 per mile. So sometimes it's too much, especially for big families and with very low income. So with that, we reduce travel needs for these communities by going close to where they live. And then we still see them here at Children's Hospital, especially when they have appointment with different subspecialties. So we try to see them on the same day in order to decrease the times that they are traveling to see the different subspecialties. We see them as an inpatient. There is reduced pricing to all UPMC contracted community, and that means some of the Amish, actually many of them, have what we call the Amish contract. So that is decreased about 80% discount for their bills, especially if they have their bishop have agreement with the UPMC, so they can get these reduced prices for outpatient and inpatient. Our goal with this program is to improve access to subspecialty care and at the end really improve healthcare in this population. There is much that we didn't know about the Plain community in Western Pennsylvania, and we wanted to know more about it because the population is growing and we see these patients here at Children's Hospital. So we did also different studies that I will talk about regarding some of the common genetic conditions and some of the new ones that we found, like MELAS, it's a mitochondrial disorder, propionic acidemia, GUCY2C, PNPT1, and others, and of course the genetic counseling that I talked about. So with that, we want to have impact on the community and have healthier community in Western PA. So these are the different studies that we do. There is basic and translational studies, and I will talk about the different ones. We did whole exome sequencing, and that's more for individuals that they don't have a genetic diagnosis to try to figure out what they have. We also do population studies. So we will be doing with the Clinic for Special Children population studies by having our exomes and their exomes and see the differences and similarities between the communities in Eastern and Western Pennsylvania. And also we offer carrier screening, although for the non-genetic conditions in the community, but some of them decide that they want to know about it, others they don't. And part of what I do in the lab is functional studies for novel variants that if they were not reported previously in the population or in the literature, and also novel gene association for specific diseases, which we're working on one right now. We did also natural history studies, especially when we have a large number of individuals with a specific genetic condition, and that's propionic acidemia. Propionic acidemia is in all the communities of Amish, and there are some Mennonites also that they have it. The GUCY2C is a genetic condition that we found within the community, and I'll talk more about it. But we also work with other clinics, like we're working on plasminogen deficiency, which is, some clotting defect, and that's with Dr. Amy Shapiro at the Hemophilia Center in Indiana. So we do try to work with other clinics, but we also have our own studies here. The studying from a genetic standpoint, and as a geneticist, studying the genetics of the Plain community is always interesting. So if you think about the originating population in Europe, so when they migrated here in the US, they have bottleneck, and over time they have a drift, and there will be increase in some of the genetic mutations within these communities, and that's what we would see. They are closed population, they have similar environment, and there are large families which are suitable to do segregation studies. So it's a little bit easier to do studies within these communities rather than the general population where there is more genetic diversity, there's less genetic diversity within this community. This is the very first, this is the proband I was telling you about. She was 13 years old, diagnosed by Dr. Walkley and Amy Goldstein. She came with a stroke-like episode, and when taking the family history, and that's why we take pedigrees and family history, we found that many individuals on the maternal side, this is mitochondrial DNA mutation, it's inherited from the mother. So we realized that there were many individuals had hearing loss, diabetes, and migraines, which are very common clinical manifestations of this M32438G, which is not only specific to the, it's not specific to the Amish, but also is seen, is common in the general population. Some actually were seen within the UPMC health system without diagnosis with cardiomyopathy. Some of them have renal failure, that they were undergoing dialysis and had kidney transplant with no diagnosis at all. So because of this patient and because of the family history that we got, we did what we call field trip. So we went to the community, and the father of the patient here, he got many family members from the maternal side, and I only have here the affected ones. So Afifa Irani was a GC, so she did the more the understanding aspect from the genetic counselor standpoint, like, and how they to accept being involved in research studies. While at that time I was a postdoc and did the lab studies. So what we look with the mitochondrial DNA mutation is for heteroplasmy level. So each cell have hundreds to thousands of mitochondria that you can see here in orange and green. And when there is if we say, for example, a heteroplasmy of 60%, that means 60% of the mitochondria have the mutation. So what I did is we got filter paper, similar to what we have for the newborn screening, get blood spots and also urine samples to look for heteroplasmy level in both blood and urine. And to do that, it was with the high resolution melting assay, having different standards here. So you can see there is like a 20%, 10%, 40, 60, 80. And the patient here, AF013 DBS, the dried blood spot, there was overlap with the 80% standard. That tells us that there is 80% heteroplasmy in the blood, while when we did the urine, there was overlap with the 100%. So that means she has heteroplasmy of 100% in the urine. And we did that all family members, and we did another trip to give them back the results and, you know, what kind of treatment or follow-up that they needed to do. That was the very first. This was my very second one. And this is a K2 deficiency. We were called for a 3-year-old patient who had immune deficiency, and he also had a hearing loss. So at that time, there was less of these clinical exomes, and we did research exome sequencing, did the analysis, and looking at, you know, hundreds of variants. There was a variant in AK2. It was a missense variant, serine to proline. And looking at the literature, so patients with reticular degenesis usually died within the first year of life if they don't have bone marrow transplant. But this kid was 3 years old, and he didn't have any hospitalizations before 9 months of age. So he really didn't present as what is published in the literature. So I had to talk to immunologists because I don't know how to explain these sophisticated immunologic testing. He said, well, I have this variant, and this patient, can you look to see whether it fits? And I said, yes, it's the picture, what you see, it fits, but it seems that it's milder. So what we did is, what I did then, very closely with Anu in the lab, functional studies on this. It was a little bit looking backwards now, bold to do functional studies, having only an N of 1 affected individual and spend a year in the lab. But what we did, so this is the gene, it's serine to proline, it's the series of the beta strand here, which when predicted, so that's talking with Walid actually because he's the expert, so it can cause a kink in this beta sheet and destabilize the protein, and that's why there is, doing Western blot, there wasn't any protein expressed in the patient compared to the wild type. And when we did also immunofluorescence analysis, the green is for the AK2, there wasn't anything in the patient in the skin fibroblasts and the bone marrow. We did additional studies, but at the end, we were very confident that this is pathogenic variant. Unfortunately, this patient died. He got second bone marrow transplant and died at 5 years of age because of complications from the bone marrow. But because of this, we were able to diagnose 2 siblings. One here at 2 days of life, we got when he was born. The blood sample sent it in 2 days at the clinic for special children. We got the results, told them he was affected, so he followed with immunology before having any symptoms. And he's currently 5 years of age, got bone marrow transplant and is doing well. And his sister here, she's actually in the Ronald McDonald House. She's 2 months old, and she was also diagnosed within the first 2 weeks, got bone marrow transplant. And so far, she's doing well. This is the only family that we know that is affected with this. Although this is one family, we did save 2 kids. We gave the parents the peace of mind that these other 2 don't have it. But we also added to the general knowledge that reticular degenesis can present with milder phenotype, and we have to keep that in mind, not only for patients from the plain community, but also from the general population. This is one of our recent ones, and this is a kid that you see here with an arrow. We were called by GI, Dr. Leah Siebold, telling us, I have this 13-year-old male who has history of chronic diarrhea, multiple hospitalizations for dehydration. And his mother is affected, but she's milder, and his maternal grandmother is affected. She had also history of chronic diarrhea and also bowel dilatation that she needed several bowel tapering surgery. So Kate and I went and saw the patient, and it was very interesting to take the family history. So what we did, Rach Wolf was the PSTP medical student. She worked on this. What we usually do is segregation studies. So we did this was a Mennonite family. This is autosomal dominant. When we did exome sequencing on the proband, we found that there is this missense variant. And we did did another research trip. So that was a Mennonite. We met them in the Mennonite church. We did consenting, get blood samples, and we tested, there was about 25 individuals. So you can see here with the black filled symbols, these are all patients that they have GI symptoms, but also they were positive. The gray ones, they were all tested. They don't have symptoms, and they were negative. And there were these 2 here. The grandmother at that time was not present, but there are these, I have problem with the pointer. These 2 with the shades, they had non-specific GI symptoms, but they were negative for the variant, so they probably have a different reason. We did another trip and consented other family members. So we did at the end test 75 individuals, and we got a diagnosis for 27 of them. We learned a few days ago that there were 5 other family members in Wisconsin that they were also diagnosed with this. So these individuals, they were all told you have Crohn's disease or you have irritable bowel syndrome, and finally they have a diagnosis. And other family members in different states, they were able to be tested for this variant. So so the GUCY2C, codes for the guanylate cyclase receptor. It's in the epithelium of the intestine. And when there is, so this is a gain of function mutation. So that means this receptor is active. So there's increased CGMP. And through different messengers, there will be activation of the CFTR and inhibition of the NHE3. And with that, there is increased chloride in the intestinal lumen and decreased sodium absorption into the cells. So there's more NaCl, and that's why these patients have secretory diarrhea. Every time we have a novel variant, we look at the literature, see where are other variants they were reported. So this is looking at the protein here. So most of the variants that they are associated with the GUCY2C causing chronic diarrhea, they were in the linker region, and that's where the patient had the variant. So I want to really acknowledge Dr. Leah Siebold because of spending a little more time to taking a little bit more history. From one patient, we had 27, and we have a novel variant in this family. Talking about reverse order, so we have about what we learned from the plain community and how to apply that to the general population. So this is actually a patient of Dr. Barkley. She's a patient who presented with failure to thrive. She has some dysmorphic features that you see here. She also have psoriasis in the skin and also in the, sorry, I'm having issues with the pointer. She had also psoriasis in her nails. So every time we saw her in the clinic, she had really these thick nails with psoriasis. There is psoriasis here around the G-tube area and the skin, but also she have this arthritis, the autoimmune manifestations in the lung, liver, kidney, GI system, but also in the joints. And she have this effusion in the kidneys, and she needed to have the removal of the fluid in the joints every few weeks. So Dr. Barkley did whole exome sequencing on her, and she was found to have only one variant. It was a frame shift variant, but because of the knowledge of this genetic condition in the plain community, there was only one publication when this patient was seen in the clinic, and it was this publication that is here. So this is 10 Amish individuals that they have itch deficiency. The clinical manifestations of the patient really fit these 10 Amish individuals. And Dr. Barkley said, well, we're missing something. So he sent for deletion duplication studies. And actually, she did have deletion of the last 2 exons that they were missed with the exome sequencing. So this is autosomal recessive. You need to have 2 mutations on both alleles. So finally, she got the diagnosis of itch deficiency. Since then, we have only this original Amish publication, but we also have individual publications for other 4, including ours. So all of these patients have the failure to thrive, developmental delay, dysmorphic features, lung disease, relative macrocephaly, and there is this differences in the autoimmune disease. This patient follows very closely with Dr. Casey Torek for many years in rheumatology. And one of the patients at CHOP who had itch deficiency had bone marrow transplant. And for the last couple of years, it was discussed with the patient to have bone marrow transplant. They were hesitant. But I'm showing here the pictures from pre-bone marrow transplant and post-bone marrow transplant. Within 2 weeks of the bone marrow transplant, she started to have clearing of the psoriasis. These pictures that you have here on the right, they are 6 months post bone marrow transplant. And you can, for the first time, we can see her nails. We've never seen, they were always thick psoriatic. And she does not have effusion in the kidneys. The skin psoriasis also resolved, and she's doing really well. So what we learn from this is also what we learn from the plain community we can apply to the general population, but also being the second case of successful bone marrow transplant, now we can go also to the plain community for patients because there is more of these patients with itch deficiency, and maybe discuss like having bone marrow transplant before having these complications from the disease. We talked about genetic conditions unique to the plain community, genetic conditions that are seen in both. And a TANGO2 deficiency is one of the genetic conditions that I actually spend a lot of time in the lab looking at the function of the gene and the pathophysiology of the disease, not because of my love to tango dance, but for different reasons. So there is a common European 3 to 9 exon deletion that is seen in the European population, but also seen in the Mennonites. This is a multi-system disorder. Usually patients are healthy, normal till around 9 months of age, where they have they start have issues with development. They can have metabolic crisis, cardiomyopathy, arrhythmias that can be fatal. But what's really interesting in this is that vitamin B5 decreased frequency of metabolic crisis, and folic acid is used for arrhythmias, which we still don't know the reason or how these function in this. So I'm going to skip a few of this, but just to say, we did lots of functional studies. These are we use the skin fibroblasts, believe it or not. You still have a lot of important information from skin fibroblasts from the patients, and none of them had any expression of TANGO2. This is a heavy, and I don't have time to go through it, but we did omics studies with previous functional studies to try to correlate what we did with mitochondrial bioenergetic, fatty acid oxidation, mitochondrial complexes, and correlate that with the omics studies that we have. The one thing that we try to do is for genetic conditions that are common in the plain community to do natural history studies. So propionic acidemia is a metabolic disorder. Probably some of you have seen some of these patients. They usually present within the first week, usually, for the general population with lactic acidosis, hyperammonemia. Most of the time, actually, before we have the newborn screening results, which newborn screening result we get in sixth or seventh day, while they can present a third or fourth day with metabolic crisis. In the Amish population, they have a common missense variant, and there is this misbelief that it is mild in the Amish patients. So, but we do know that they have cardiomyopathy, and we know that they can present with metabolic crisis, although very rare. We never had any patient presenting with metabolic crisis in the plain community in the first week of life, like we see in the general population. But we wanted to understand more about this. So this is why we did the natural history study. And there were 3 centers, our center, the UPMC Children's Hospital, but also the New Leaf Center, which is in Ohio, and the Community Health Clinic, which is in Indiana. And for the patients that they are in Ohio, actually, Kate Walsh-Vagley did go with the nurse of the New Leaf Center and knocked door by door for these individuals that they have propionic acidemia, did the consenting there. They were notified earlier by the New Leaf Clinic that they will be going to their homes to do the consenting. So we did the consent, get all the medical records, and we did, Sarah Ehrenberg, medical student, did a review of the data. I just want to say that from this slide that some of the patients with the propionic acidemia get missed from the Amish because they can have normal or near normal levels, and some they were told by physicians that there is no need for follow-up because it's usually very mild. But and this is also a heavy slide, I'm not going to go through it. We have patients that they are very compliant. We need to do protein restriction because they cannot metabolize a specific amino acids, and they get a formula that is safe for them, and they can without any issues. And there are specific medications. So we have patients with protein restriction, formula, no formula, or no protein restriction with formula and no formula. And I just want to show here the percent of the cardiomyopathy. Almost all of them, or the majority of them, had cardiomyopathy, whether they got treatment or not. And that was very important for us to show, even though we knew it, but also to show it and publish it, say, well, these patients need to be seen in genetics, even if they don't have metabolic decompensation usually, but they have high risk for cardiomyopathy. And one of the things that so that was, there are guidelines, European and American, for how follow-up for patients with propionic acidemia, but also, well, the one thing we added is cardiomyopathy is really one of the most common outcomes in Amish patients, even though that they appear normal or mild, I mean. But also the other thing, we know there are other genes that can cause cardiomyopathy in the plain community, and we need to screen for those because we have some patients that they have more than one genetic condition, just to see, because that will affect also the way how we'll manage them. So it is a very long, steep road to still learn from the plain community and the genetic disorders in the Western Pennsylvania. But we will continue to work, and the one thing that probably a message leaving, with this is to please contact us. We have different resources for the families. I know sometimes, it's hard when thinking these families don't have insurance, but many of them have discount. We have also resources to have low or free genetic testing. So there are things that we can do. And sometimes that at the end will actually decrease the cost of their hospitalizations by knowing the genetic conditions that they have. One of the things that we are really looking forward to is collaboration with the Hemophilia Center, which I got called a few days ago. They do have outreach clinic 3 days a year because there is a hemophilia B in the Amish community, and there is about 50 individuals go to each of these days, and we will be there so we can, those families that they have questions about other genetic conditions or whatever in the family, then we can see them, take pedigree, and let those that they would need genetic evaluation come to our outreach clinic. There are lots of people to acknowledge, even though 3 people go to the outreach clinic, but really the clinical genetics team, because they see these patients as an inpatient and then they hand them to us to see as an outpatient. Jerry Barkley, we worked together on this, of course, for many years. Kate, who just retired, she was instrumental. Walid, because every variant, everything, I go to his office. Too many people that they were involved in the Jerry lab, but then too many students, undergrad, grad students, and master students, GC students, that they were involved with different pieces of the different research that we did. And I'm happy to take any questions.